Welcome to Consulting Chai. Welcome to another episode on hospital basics. Today I'll be covering about finance. The reason why finance is very important, it is one of the four very important pillars of hospital. First one is the operations, second is the HR, third is marketing, and the fourth one is finance. Apart from this four, to run everything, you have to have a good quality, and another aspect of to have a very good design. If these four things are considered, like the infrastructure and the quality, then only the hospital will run smoothly. Any of these things are compromised, then you will face difficulty in running the hospital. So that is the why we are covering this. Hospital operations and finance, it's never about extracting the maximum from patients. It is about providing every necessary service without adding the unnecessary. It is to ensure that no important care is missed while the hospital grows through honest, patient-centered practices. I'll be covering about capital expenditure, operational expenditure, then annual budget, and then your daily reports, your monthly reports, your doctor's report, and then finally the financial indicators. So CapEx, it is where the whole thing starts. When you plan to make a hospital, you start with the total budget. So in total budget, we have learned MBA that debt equity ratio is 2:1. But good to have a equity of 40%, debt not more than 60%. Inside the debt, your long-term loan and your short-term loan, out of those 60%, 48% should be your long-term loan, and the short-term loan should be much lesser, about 12% of the part of the 60. Rest is the equity. So in CapEx and the OpEx, the total of your CapEx, you should try to make it less than 55%. Lesser it is, it's better. In many cases, why many hospital they pay off their EMI, their loans when they start, is because in the beginning, lot of these hospitals, they run in loss expenditure and what they are earning. So you should have that cushion of manage the operational expenses. So that is why if you keep most of the part of your total budget in the operational expenses, then it is easier for you to sustain these are the parts of CapEx, like civil structure, mechanical, electrical, plumbing, firefighting, medical gas pipeline system, the interior work that you need to do inside the hospital, the equipment that you need to purchase, the furnitures that you have to buy. So all these things consist of your CapEx. So let's try an example here. So if your total budget is, say for example, 20 crore. So your debt should be around 12 crore and your equity should be 8 crore. And your long-term loan should be approximately 9.6 crore. Your short-term loan should be 2.4 crore. And rest 8 crore you keep it for operational expenses. So here we do not consider the land cost and design development, that turnkey consultancy. And if you break down the CapEx, 35 to 45% of the CapEx is civil structure. MEPF around 25 to 35%, MGPS 4 to 8%, interiors 15 to 20%, equipment 20 to 30%, furniture 3 to 5%. So whatever I've said, whatever numbers I've said, these are just approximate values. It will always change from project to project. So now let's go to the next point. Your operational expenses. So in this diagram, you have to watch on YouTube to see the whole diagram. So I've made a fishbone diagram here. The blue lines are the ones which are actually making you money. These are revenue generating departments, and the red ones, these are all cost centers. Okay. So as you can see in this diagram, the blue ones are the ones which is pulling the hospitals toward its positive profit side. And on the left hand side, the red ones, they are the ones these are the expenses. So like your MRD, human resource, your supply chain, your maintenance, laundry, IT, BME, biomedical engineering, securities, and your utilities. All these are cost centers. And departments like physiotherapy, chemotherapy, OPD, ward, ICU, emergency, pharmacy, OT, cath lab, radiology, blood bank, kitchen, canteen, lab, NICU, PICU, labor room, even dialysis, and there can be more departments. We need to see these departments whether these are functioning well, they are on the positive side. Operational expenses. One part is your salaries and incentives that you give to your staff. Second is the utility. Then your outsourced services. Then your certain variable cost like your repair and maintenance. And you also need to see the adherence to the budget. We'll talk about budget in more detail in the next slides. From this diagram, you can see these operational expenses are all part of the red fishbone part. So let's go to the next point. Now comes the annual budget. It is very important that you have an annual budget. In a hospital, if you don't have a proper annual budget, you will miss out on a lot of things and your finances will go haywire. The first part is operational expenses. So the percentages that I'm sharing here, this can vary from hospital to hospital. So say for example, it has about 60% of your total budget, operational expenses. And then your capital expenses around 20%. Your the expenses that you do in quality adherence 8%. Compliance 2%. Contingencies and reserves, you have to have a buffer for that, so around 10%. Okay, and then you need to prepare the preparation timeline for annual budget is before the financial year starts. February to March, you should start prepare and finish the annual budget. And then after preparing, you also need to look into it, revise it. So always better to complete it by first or second week of March. Okay, then you have your revenue projections. Revenue projections are important because you need to tally with the budget, your expenses and everything. It is going hand to hand with the revenue projections. Your revenue should always be more than what you are spending upon, what you are spending. Okay, then we have certain budget matrices. To detail this, all these points, the operational expenses consist of your salaries and the benefits that you give to your staff, which will be approximately around 50% of the operational expenses. Your medical supplies 20%, utilities, that is your water and electricity bill, around 10%, dietary services, spending on your canteen 5%, admin and overheads 10%. So again, I'm saying these percentages are all it will all depend upon hospital to hospital. Then capital expenditure. This is not the capital expenditure that we do initially, but a capital expenditure that we have to do from time to time in terms of infrastructural development, in terms of certain equipment that we need to procure in IT systems. When we need to add certain modules, we need to upgrade the IT system. Those are all under capital expenditure. Then in terms of quality, for NABH implementation, NABL implementation, JCI, or any quality driven things that you're doing, any training expenditure that you do, all comes under the quality. And then compliances for staff welfare, your EPF, gratuity that you do, okay, certain insurances that you provide, all those comes under compliances. Contingencies and reserves. Roughly, you should always have OpEx of for at least three to 6 months of your operational expense should always be there. So this much liquidity you should maintain to have a healthy financial management practice in your hospital. Preparation timeline for annual budget is February to March. I have covered that. Revenue projections, it is to understand that your annual budget that you have made, the planned and the actual, it's not deviating much. Through good financial management and through good operations, you should always try to make your expenses as less as possible, but at the same time complete all the work that you're supposed to do. You have to tally it with the revenue projections. Okay, so revenue projections, patient revenue around 80%, insurance claims 10%, government grants 5%. Again, I'm saying this percentages will vary from hospital to hospital. And then your budget metrics. So in budget metrics, you need to aim for a profit of 10 to 15 surplus. So the revenue projections that you do, the profit predictions, the forecast that you're doing, you should try to increase it through various means. Through various means, all ethical means, I'm saying 10 to 15% surplus. Salaries should be less than 50% of your revenue all the time, and you should at least quarterly you should monitor the variance of your annual budget, quarterly budget, and the revenue, and what is the variance. So this is how you should be doing the budget, and you should be monitoring the budget. So these are the list of details that you need to get at the end of the day. Our daily report will have these contents: collections, what was the revenue collected on that day, then outstanding accounts receivable, then your cash position, your key ratios, and revenue summary. Collections like your cash payments, your card, UPI transactions, online transactions, your TPA realizations, and your total overall collections for the day. The purpose of this is to monitor your cash inflow as per the billing that you have done. So the billing details along with the collection, it is required. Then your outstanding receivables, account receivables, like your pending TPA, your corporate bills which are pending, your patient advance, certain credits of your patients which were due, and aging analysis. We'll talk about the aging analysis. It's basically your debt service coverage ratio. In the later stages, we'll talk about that. So the outstanding receivable is to understand the bottlenecks of your collections. And cash position, it's a very simple one: your opening balance and how much you have received, or the deposits, and how much payments you have made, and then the closing balance of the day. This is to ensure liquidity of the operations. Then comes your key ratios. We'll talk about these key ratios and these indicators in the later stages. That is slide number 7. Collection efficiency, AR, your DSCR, that is your debt service coverage ratio, and cash to billing ratio. So these are for your early warning indicators. Then your revenue summary as in your OPIP billings, how much billing has happened on that particular day, and your pharmacy sales, your lab and radiology sales, your TPA insurance claims, how much claims you have made. So that is to track your daily income by these departments. Okay. You go on tracking your daily finances, and at the end of the month, you need to have a bird's eye view, overall view of what had happened at the end of the month. So first is the overview. In overview, you see your total revenue versus budget. So what was planned and what happened in actual, you have to compare that. Then your net profit, you have made net profit or it was a loss. So the whole month, what was the ultimate outcome? Then certain key ratios will again cover about very important financial indicators in the seventh slide. Then the major variance explanation. So if certain variation has happened, why it had happened, whether it is positive, then why, what did we do, so and what had happened which made it positive, and what had happened why it was negative. In this overview, it provides the leadership with instant snapshot of the financial health, and it also highlights critical issues needing immediate attention. Okay, it sets context for the further detailed analysis. And then comes your revenue analysis. We see revenue from various sources. So this tracks revenue performance against budget by several by service lines. Okay, and it supports resource allocation, and it supports that resource allocation decision. Then comes your expense analysis. In expense analysis, you see your salaries, your utilities, variable cost. So it monitors cost control effectiveness, how well we are able to control the cost effectively, and any flags flags of budget overrun can be seen through this. And it also guides cost optimization initiatives across several categories. Okay, then comes your payment and amortization. Amortization is basically the part of a principal part of EMI that you, so loan payment and amortization. So the cash flow prediction and liquidity management is helped here. Financial planning and budgeting can be done. Tracking the loan payments and amortization, you tracking to prevent financial distress. If it is not seen, then one day where you feel like you're overburdened by the EMI of the loans and you're not able to repay back, there's a cash crunch going on. So when you track these things and you're able to pay those EMIs on time, gives a lot of confidence to the bank. Then comes your receivables aging. It identifies the collection bottlenecks, and it prioritizes follow-up actions, and it prevents bad debt accumulation. So this is also a part of financial indicators. We'll cover that. TP insurance claim submitted, received, major payer delays, and denial analysis. There are certain companies where you can outsource the whole TPA. Through that, your realization of cash is very fast. The rejection rate, it drops tremendously. So it tracks insurance reimbursement delays, it manages payer relationships, and it forecasts cash flow accurately. And then comes your cash flow statements. So cash flow statement, simple: opening balance, cash inflow, cash outflow. Then you have the net cash flow, and then in the end you have closing balance. This is similar to what we saw in daily reports. And then we have departmental performance. Department wise, we have to see which departments are performing the best and which departments are having a negative cash flow. We cannot do anything until and unless we identify where the problem is. So that is why this exercise is very essential to be done on monthly basis. Okay, and then your CapEx update. So initial CapEx is one thing, and monthly tracking the CapEx is another thing. Any major equipment purchases or any infrastructure updates or AMC calibrations needs to be tracked. Even if you don't have to do this expenses every month, but you need to put this in your system so that you at least track this. There can be any month where you may need to some equipment purchases, or you need to do infrastructure updates or AMC calibration, all that. Doctors report. As we know, doctors, they are the engines who are making the hospital run. This analysis should not be taken like a target system where you are asking the doctors to do this, and giving them certain target. That is not the right thing to do. It is unethical. What we should be focusing is providing an environment for the professional growth, so they are happy to work. I'm repeating this thing again. So hospital operations and finance, it's never about extracting the maximum from patients. It is about providing every necessary service without adding the unnecessary, ensuring that no important care is missed while the hospital grows through honest, patient-centered practice. So the contents of doctor report would be: number one, doctor wise, you'll have number of patients in OP and IP, then the net revenue of through that doctor, the salaries you're giving to the doctor, salary or it is case basis, whatever it is, and then your net surplus, whether you are in profit or you're in loss, the OP to IP ratio, and then your revenue per patient for each doctor. So the purpose is to help doctor equipped with proper infrastructure and equipment, and you take feedback from all consultants and understand what do they need. If there is negative, how to make it positive, and if it is already positive and it is huge, then what the hospital management can do in order to grow their practice even more. Now the financial and operational indicators. So operational indicators starts with OP-IP ratio, the number of OP and the number of IP the hospital has done, and the number of emergency cases and number of IP cases, number of IP cases to ICU ratio, your IP to OT ratio, and then comes your bed occupancy rate, average length of stay, and your OT utilization. So bed occupancy rate, the formula is number of inpatient days divided by number of beds into days in a month, multiplied by 100%. So that is your bed occupancy rate. Bed occupancy rate, a healthy bed occupancy rate is around 65. More than 65 is 65, 70. It's good bed occupancy rate. So even if you are planning for a nursing college or medical college, along with your hospital, nursing council, medical council, they have requisite bed occupancy rate requirement. Then your average length of stay, which is calculated in a numerator, you have number of inpatient days. In denominator, you have your number of deaths and discharge, including LAMA. So average length of stay 3 to 4 days, it's good. If it is more, then it means maybe some case of infection, or the patient actually very sick and you're keeping the patient for a very long time. But in general, 3 to 4 days is good for average length of stay. Then you need to track your OT utilization. So OT utilization in hours in the numerator, in denominator you have total OT functional time. So there are certain OTs which are available 24 hours. In many hospitals, smaller hospitals, or even big hospital, they don't function the OT 24 hours. They have 2 shifts, and only in case of emergency the OTs are open. OT utilization in hours divided by total OT functional time multiplied by 100%. So that is your OT utilization rate. Then comes your financial indicators. So in financial indicators, number 1, it's EBITDA. So how do we arrive to EBITDA? So EBITDA calculation is total revenue. Say for example you have 100 rupees as total revenue. You have to subtract the COGS, that is cost of goods sold. Say for example it is 20. Then what you get is your gross profit. From gross profit you have to subtract your variable cost, then you get your marginal cost, then you have to subtract your fixed costs like salary, utilities, all that. Then what you get is EBITDA. The purpose of calculating EBITDA is to see your operational cash flow is good. EBITDA more than 15% is a healthy EBITDA. And then next important indicators is your RPOP. RPOP is average revenue per occupying bed. So RPOP is calculated as, in the numerator you have total revenue, which has to be divided by number of beds multiplied by your bed occupancy rate. So the total revenue, when you calculate it monthly basis, then you can divide it with 30 or 31, whatever days of the month you have, and then you have the daily RPOP. So this shows your bed revenue efficiency. So in this table I have shown, this has been taken from IND Money. So this is a financial year RPOP per day for these corporate hospitals in the financial year 2024. So Max Healthcare, they have RPOP of 76,900, Medanta 63,000, Fortis 57, Apollo 56, Narayana about 41,000 a day. This is their RPOP. So you can calculate your RPOP with this formula and see where do your hospital stands compared to these corporate hospitals. Then you have your PAC. PAC is hospital finance. PAC is patient acquisition cost. So it is calculated, in the numerator you have marketing cost divided by your number of new patients that you get in that particular month. So the purpose is to understand the marketing ROI. Then you need to see your DSCR. So we had spoken about DSCR in previous slides. So DSCR is debt service coverage ratio. So it is calculated as EBITDA divided by your EMI plus lease payments of that month. Okay, so the purpose of this is to understand the loan repayment capacity. So when there is a valuation being done for a hospital which has to be sold, they are not doing financially good. So to arrive to that valuation, DSCR is essential. So how strong your profits are to be able to do the loan repayment. A healthy score of DSCR is more than 1.5. And then comes your AR days. AR is accounts receivable. So accounts receivable is calculated as, in the numerator you have average accounts receivable. In the denominator you have total credit sales, which has to be multiplied by number of days of that particular month. Then what you get is AR days. So it basically shows you your collection efficiency. So if your AR days is less than 30 days, then it is very good. If it is between 30 to 60, still okay. AR days of 60 to 90 days, it's not a good one. And any AR days more than 90 is a very, very bad one. So this is where we end our financial and operational indicators. And also this is the end of this video of financial management. So I hope you like this video. If you have seen this video till the end, thank you very much. Please like, comment, share this video, and subscribe and hit the bell icon to get more such videos. Thank you for watching. See you soon.